Very delighted to be here to talk to you about what we've done in the last, I guess, 6 months. So just summarize the organization I work for, Multiple Sclerosis International Federation. I'll call us MSIF because it's much less of a mouthful. We're a global network of 48 organizations with links to many more around the world. Next slide, please. Sorry, my voice today. So we first got involved in COVID data sharing really because it was very much driven by questions we were receiving from our patient community. Questions both to us as an international organization, but also to many of our members. Right at the start of the pandemic, people were nervous about what it meant for them as people with MS. Were they at greater risk of catching COVID? Were they at greater risk of more severe symptoms? Were the drugs that they were taking putting them at greater risk? So right at the start, we gathered together an international group of MS neurologists and researchers to try to come up with some advice that we could give to our patients and our patient organizations to help. I think at the time, this was right at the beginning of March, there were only 3 documented cases of COVID-19 in people with MS, all in Italy, and all 3 in the hospital at the time. So we produced some advice. It was definitely on the more cautious side because we were largely drawing on these 3 cases and also on clinical expertise of what we assumed might happen to people given the drugs they were taking for their MS. But there was a very clear message in that first consensus meeting, which was we really needed data. We needed to start activating people to collect data, and we needed to share it rapidly so that we could start addressing people's questions in a much more evidence-based way. Next slide, please. So I reached out to Professor Lisbeth Peters, who is a data scientist at the University of Hasselt and also the chair of the MS Data Alliance. And I reached out to her to ask her what we could do on a quick scale to try to help the community get together and start collecting and sharing data. So we very rapidly set up the COVID-19 and MS Data Sharing Initiative, which launched at the end of March, so within a couple of weeks of the first COVID advice meeting to launching the initiative took a couple of weeks only. And these are some of the partners who came on board right from the start to help us with developing how we were going to manage the data and analyze the data. And also Quamenta, who are a cloud-based data platform, kindly provided the services for us to develop a global platform. We had 3 objectives with our initiative. The first one was to scale up collection of data from people with MS and developing COVID. We decided right from the start that we would do this not by setting up a new study, but by actually reaching out to existing MS registries and cohorts. We knew that everyone wanted to do something. Everyone was starting to think about collecting the data. So we thought the most effective way would be to try to harmonize these efforts and build on the existing infrastructure rather than set up something new. So we reached out to many of our networks and got them on board and first agreed a core set of variables that we would try to encourage all the registers to be collecting. We managed to do that within 48 hours. So by the end of March, we'd launched the initiative and we'd all agreed on a core set of variables that we could collect. And we then activated the registry to go and start doing the work. Another key advantage of working this way was that it made the ethical approval much easier because each registry was responsible for amending their ethics, and we could then just get essential ethics for the sharing and the aggregation process, which, because we have used de-identified anonymous data, was much easier. MSIF also, at this point, launched a communications campaign to try to activate our communities to take part in the initiative. We reached out to our patient organizations, but also our clinical networks. The second objective was very much around speed. So we wanted to trigger increased data collection and sharing, but fast, because we really wanted to be able to start providing answers to our patients during the pandemic. So that meant we adopted some many pragmatic solutions to the way we did it, but it also meant we developed a really inclusive data sharing architecture. So we encourage both patient-reported and clinician-reported data to come into the initiative. And I'll talk through as well. We also allowed people to share data from their own registries, but also to directly input into the central platform, so that as many different groups around the world could take part, rather than kind of being very saying, you know, we'll only take this one kind of data and it has to come into us this way, which would have required a lot more work in the different countries, and I think would have probably slowed us down. There are, of course, some negatives to have including so many different kinds of data that we can talk about a bit later. And then our third objective was to act as a stimulus to steer ongoing research. So yes, we wanted to be fast and we wanted to get some insights during the pandemic, but we also wanted to do this in a way that the MS community could learn. We wanted to create and test some new data sharing architectures and build new collaborative networks, especially with areas of the world that we haven't really been able to work with before, such as Latin America. Next slide, please. This map just shows you our current data partners. So we have 20 data collection partners from North and South America, Europe and Australasia, all collecting and sharing data with us. There are obviously quite a few areas of the world not indicated on here because they don't have existing registries and cohorts. And so we encourage these areas of the world to report directly into our global platform. Next slide, please. And this shows the quite complicated data architecture that was the creation of Elizabeth Peters at the MS Data Alliance. So just to try to explain this to you a little bit, there's 3 ways that data can come into our project. Direct entry into the platform, either by clinicians or by patients. And patients can enter it in Spanish, in French, or in English. Patient registries and cohorts can then directly share de-identified anonymous patient level data with us directly, or we then, some of the registries we were working with, this wasn't possible, even sharing de-identified data, it was still not in compliance with their data privacy regulations. So we then introduced a third mechanism which is often known as federated data sharing, where the same analyses are run across multiple cohorts, and then they can just share their counts with us, and we can aggregate their counts into one big data pool. Next slide, please. So this summarizes the current data set we have. We've amassed records on nearly 9,000 people with MS from 82 different countries. And you can see that there's quite a difference between cases that are reported by patients and cases that are reported by clinicians, with many more clinician-reported cases being suspected or confirmed positive for COVID, and also having more serious symptoms. So many more of the clinician-reported are hospitalized and requiring ICU compared to the patient-reported. And this is what we expected, but actually it was more striking than we expected to see that there's quite a bias between how the data is reported. So for that reason, moving forward, we have kept the 2 kinds of data very separate in our analysis. We haven't mixed them. The variables that we collected are listed on the left of the slide. And so we've just presented the first results from this initiative at the International MS Virtual 2020 conference, and we've submitted for publication. And the key findings are in this blue box. So it was actually really reassuring for our community to see that people with MS have similar rates of developing COVID and dying from COVID-19 to the general population. There are some predictors of a more severe COVID-19 infection. Some of these are what we see in the general population, so age and also male sex, but some are specific to MS, so the type of MS and the level of disability a person has also can predict a more severe COVID case requiring hospitalization and ICU admission and death. And importantly, one class of MS therapy that's regularly used to treat MS, a disease-modifying therapy, is also associated with more severe COVID outcomes. Next slide, please. So outcomes and learnings, our first 2 objectives we feel are definitely met. We've been able to scale up data collection within our community and we've rapidly shared and amassed some insight that has been able to inform how we are helping our patients during the pandemic. So although we haven't published the results yet, as Jess mentioned at the start, MSIF have been producing global COVID advice for people with MS that has been regularly updated. So as the data was coming together and being analysed, that was presented to our clinical advice group, and it has been incorporated into the global advice. So people know that there is a risk for one of the groups of MS therapies. And we have heard, we just met last week to update the advice again, and we've had clinicians from places like Lebanon telling us that there's nothing else for clinicians treating MS patients in their countries than this advice, and so they really are using it, and it's informing the discussions that patients are having with their doctors about treatments during the pandemic. There were some other positives coming out of this work. So new registries and studies have been established in areas of the world where they didn't exist before. So interestingly, North America and Canada actually don't have an MS registry, but they've created a joint one called CoVMS just for the COVID pandemic. And they aligned with our data dictionary so that they could harmonize with the global effort. And then some of our patient organizations in Latin America began collecting patient data for the first time from their patient communities. And that was very much triggered by this. They were able to learn from some of the other members in our kind of consortium, and we were able to give them advice on ethics and the steps they needed to go through to begin to set themselves up to do this. The other really significant point was that global data sharing was essential to spot this drug association. So there have been several national studies published that haven't been able to see this. I should have said at the beginning, there are 17 disease-modifying therapies approved for MS. So if you think about the numbers of people with MS who also get COVID who are on a given drug, it's actually quite small within each country. So we needed the power of global data sharing to be able to see these signals. We feel that we've really achieved unparalleled collaboration in such a short time, and a big facilitator was the existing global networks that both MSIF have, but also MS Data Alliance, and we were able to motivate them very quickly with a clear shared mission. Objective 3, to continue and underpin future research, is still ongoing. One thing we've definitely learned is that working as fast as we did has compromised some of the long-term sustainability of the project. We haven't really designed the infrastructure in a way that would facilitate solving questions down the line. So it may be that we don't use the data sharing initiative architecture that we have moving forward, but what we will definitely use moving forward is the collaboration and the networks that we've built to continue working together on global questions.